The Dana-Farber Cancer Institute rocked the cancer world this month by dropping its longstanding partner, Harvard Medical School affiliated Brigham and Women's Hospital, in favor of building a new cancer hospital with Beth Israel Deaconess Medical Center, also a Harvard Medical School affiliate. Well, what does it all mean for patients, physicians, and healthcare costs? And is this just a local Boston story, or is there broader meaning for the U.S. healthcare system? Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the president of Walgreens Health. So, David, is this just a Boston story about two hospital and Harvard affiliates duking it out for real estate, or is there something more here?
Well, I mean, I think it is, yes, a Boston story for sure. But, among stalwarts in the industry, I think everybody's heard of Dana-Farber, Mass General. Many have heard of Beth Israel and Harvard as well. So it's very much a Boston story, but it's not unique to Boston. There are other places around the country where you see the top medical centers, Mount Sinai in New York, Stanford in California, and University of Texas, the MD Anderson, also building dedicated cancer hospitals, John. So there's a bit of a trend, even though a lot of other parts of healthcare are going more toward outpatient. So it's not just Boston.
Well, I actually think I think that the two things that are happening that are relevant to folks, I think, are continued consolidation of hospitals as they look to sort of become master contractors and control their own destiny, particularly at a time when their margins are being stressed and they're fighting it out with managed care companies. The other kind of interesting theme from my perspective is focused cancer hospitals, because I think one of the things that was true of hospitals in the last generation is they wanted to be a place where they did everything from orthopedic surgeries to cardiac surgery to cardiac care to cancer care and cancer surgery. And this notion of a focused factory is really had some success at places like City of Hope, MD Anderson, Memorial Sloan Kettering. And if you look at the top National Cancer Institute ranked cancer institutions, the places that are getting the most, that are sort of the top of the top, because you can get cancer care everywhere. It is disproportionately, although not exclusively, represented by cancer-focused hospitals, even though there are some great institutions like the Harvard affiliates, MGH, Mass General Hospital, Johns Hopkins in Baltimore, that are also showing up on that list. And so I think that I guess I'd unpack it and say, should we be, as consumers and as potential patients, since cancer is still, I think, the second largest killer in the United States after cardiac, should we be worried about hospital consolidation from a patient perspective?
John, we're going to have a chance to see both of those models play out here in Boston. A lot of the places you're talking about are dominated by one system or another. Now, MGH, even in the name, is Massachusetts General Hospital. They are going to be taking the approach where you're within a general hospital and you've got a cancer center. And that is also, it's different from what's going to happen with the Beth Israel and Dana-Farber, where they're going to have a particular focus on cancer. Now, the argument to have the broader one is that patients with cancer, they don't just have cancer, and also that the complications arising from cancer or the treatments causing certain side effects are going to affect things, and you're going to need cardiologists, nephrologists, and so on, even if they're not specifically focused on oncology. Now, the truth is, John, right now, Dana-Farber is connected by a bridge, a sky bridge over to Brigham, and this new hospital is just going to be down the street. So we're not talking about being that far apart. I don't know how much difference it actually makes in practice. And I also am not sure if I agree with the focus factory model. I see that more for things like hip transplants or things that are really sort of cookie cutter, and those can be focused. Whereas general hospital and even cancer, it's pretty complicated and each patient varies a lot.
So that's I think it's really the jury's out on whether, and because there are clearly examples in the top cancer institutions in terms of like the top cancer institutions in the United States, have the NCI have a higher survival rate, and it's a mix, to your point, of general hospitals and focused cancer hospitals. The next question from a patient perspective, if you're okay because you're just switching the title and playing around with the ownership, is doesn't hospital consolidation typically lead to higher prices?
Yeah, it does. And here too, we'll have to see because there's some counterbalancing forces. So in this case, what's happening is the biggest and strongest hospital system in Boston, which is formerly known as Partners, now Mass General Brigham, they're losing out to more of the upstart, which is Beth Israel, Leahy, which is also pretty big and is getting bigger. So what you're having is actually less consolidation and more head-to-head competition. Now, so there's less consolidation. On the other hand, you could also say, well, you're going to have more spending, right? Because there's going to be a bit of an arms race, which is ultimately going to cost folks. The Mass General Hospital, I'm told, is already ramping up its advertising. They're going to be investing. And then you're going to have this new entity that's investing. So there's a concern about just like how much money is being put in and who's going to recoup it.
And so, David, who ends up paying that bill?
Well, hopefully somebody in Washington as opposed to in Boston.
Well, that's everybody, though. I mean, I guess the question is, can these? I thought the attorneys general were going around. I mean, one of the biggest challenges in the U.S. healthcare is increased costs. The biggest chunk of cost in the U.S. healthcare system is hospital systems. There's been a ton of research that says hospital consolidation, when two hospitals combine, one buys another or they merge, that costs typically go up. I mean, are the attorneys general and the hospital rating authorities just asleep at the switch here? Like, what's
Well,
because I mean, what as a patient, it doesn't sound like we should be worried as a family that's got some members with folks who are fighting or cancer survivors. So I'm not worried about my mom or my other relatives who've had cancer. That's great, but aren't we all going to be paying a higher price?
John, I think this is where we have to talk about value-based care and if we believe it and where it's going. So we actually have seen a tailing off of spend per Medicare recipient over the last few years. Largely, we could argue because of Medicare Advantage and focus on value-based care there. And
unpack that. I mean, do you want to talk, maybe tell people, share with people the trend of Medicare cost increases and what's happened over the last 5 years?
If you look at, we've had these conversations for a while, John, if you looked at the trajectory of where Medicare spending was going, it's basically Medicare is going to bankrupt the whole country. And though we've had debates about things like the pandemic expenditures and the huge tax cuts, Medicare is actually a bigger driver. And there's been, like trillions of dollars that are cut off of what we expect to end up paying over the next 15 or 20 years because the increase of cost per Medicare recipient has very much flattened out over the past few years. And it's a trend people haven't necessarily noticed that much. So my point, John, is that Thank you,
Obama.
If that's right, if you have two competing hospital systems, in the olden days, you'd say, hey, they're going to spend more, they're going to bring more people in and so on. Now, if they actually have kind of care on a budget and they're being actually rewarded based on outcomes, you have a possibility that the one that is actually more efficient and better wins more patients without driving up costs. That's the vision. I think it's possible.
Yeah, I think you're delusional, David. It's not the first time. So let's talk about how we should measure whether we're winning or losing the war on cancer, and then tie that back because I think your buddy President Nixon, your model, President Nixon, I believe was the first person to declare a war on cancer, and in many ways we are winning. A little bit like Ukraine, grinding it out by the yard. And then you have Biden to bookend it with his cancer moonshot. Can you talk a little bit about cancer trends and what people should be thinking about? And then let's talk about perhaps how we can measure the success of this from a treatment, care, and incidence perspective. But what are the cancer care trends? And I think based on the numbers I've been looking at, we've been actually doing pretty well.
So, John, you mentioned early on in the podcast that cancer is the number 2 cause of death, and it is. That's actually been the case since the 1930s. So it's heart disease is number one, and then cancer is number two.
Not
But
all, not all of us are that old, but thanks for bringing it up.
no, some are, but including some people, who are around today. If they're in their 80s, they were around at that time, and so there's a lot of cases, about 2 million cases a year, and about 600,000 deaths. However, the death rate has declined by about a third since 1991.
And
although
it's been grindingly consistent. So although people may not realize it, we actually are making pretty dramatic, to talk about breaking the back of the cost curve. That's pretty impressive, right, David?
well, in terms of the incidence, now the cost has gone up because there is more. I mean, so the overall cost of society has gone down, right? Because more people are alive. So that's very good. Therapies are
like
expensive.
4 million lives that we 3.8 million, I think, is that we would have lost if we hadn't cut the cancer death rate consistently since 1991.
So this is where, when we talk about the U.S. healthcare system not getting what we pay for, in cancer, arguably is an exception or even the exception to say, yeah, this is why we have an expensive healthcare system, to reduce deaths, suffering from cancer. So we have that happening. Now, there's some concern about what's going on, and there have been more like anecdotal information for the most part about younger people getting cancer and getting more aggressive forms of cancer. I think the statistics, long-term statistics, haven't played out yet there.
Well, I disagree, David. I think you see a modest increase in pediatric cancer pretty consistently, and the incidence of cancer is still relatively high. We're just getting better at healing, managing, and turning it into more of a chronic, not in every area, but chronic condition. I do worry about that, but unpack some of those statistics and maybe talk a little bit about some of the health equity concerns as well.
Sure. So I think the biggest driver why we will have more cancer cases is that the population is aging. And still the single biggest predictor about whether you're getting cancer or not is how old you are. And so there will be an increase in the number of cancer patients, even if the incidence by age drops off. Now, in terms of disparities, there's very significant racial disparities in particular. And so if someone doesn't have access to primary care, screening, and so on, what happens is when they arrive at, let's say, Dana-Farber, where they'll still have access probably from, due to Medicaid, or just that's where people will be taken, their cancer may be at a later stage, more aggressive, and say, gee, if I'd seen this a year ago, we could have treated it, and now we can't. So those disparities are less in incidence, but in outcomes very much because of the early detection and treatment. And just also, getting cancer care is inconvenient. Sure, you could put everything aside, but not if you can't afford not to work. People with cancer actually, believe it or not, don't pursue all their treatments. They still have to make trade-offs between putting food on the table and getting treatment.
And so there are economic and racial disparities, and you're seeing it particularly in the success rate in curing and managing prostate cancer for people who are not of color, and the increasing incidence and death rate, which is not changing, and in fact is increasing as a difference between white and non-white populations. I think that number is terrible. The other interesting number that I saw is that that cancer still is in many ways a bigger challenge for women based on incidence than men. Incidence is going down for older men and up for women. What's going on there, David?
Well, I mean, there's a couple things, and the news isn't quite as bad as those recent statistics would suggest. So one reason that cancer has gone up for women is that women in the last generation have started acting more like men, more drinking, more smoking, and so on. So you see some of that happening. But one thing that has happened too is that you don't normally think of vaccines for cancer, but the HPV vaccine, which has now come out, is that women in their 20s, who was the first generation that actually got the HPV vaccine from the start, they have a much lower incidence of cervical cancer. Now, cervical cancer isn't high in people in their 20s in general, but as a precursor, we may see some of these preventive activities. Well, I think
you've seen the death rate go down by over 30%. I mean, it's actually, while it's not as commonly used as you'd hope, because it really does work, the death rate's gone down dramatically. I mean, can you maybe talk a little bit about some of the other things that that are exciting about cancer care in terms of either curing cancer, which is sort of a shocker, or managing it. And then talk about and then we can maybe get into how this all plays out given the merger, or whether it even does.
Yes. So we generally talk on this podcast about care moving, from high acuity settings to lower acuity settings, and in particular the home. And now we're talking about, which type of hospital is better for cancer, a focused one or one that's within a general hospital. That's not normally our discussion. And so one of the key questions is whether these trends toward the home, whether those play out for cancer or not. Now, to some extent, they do. When you talk about becoming more chronic, we have things like infusions, maybe even chemotherapy at home. But there's some other therapies like CAR T therapies, immunotherapy and some complicated surgical procedures that actually really have to happen in a hospital. So some of the more complicated and advanced changes in healthcare, some of the things that are bringing us forward, are expensive, and they actually occur in an acute environment. In fact, at the Brigham, something like 40 or 45% of their surgery volume is for cancer. So you think about surgery, I wouldn't have guessed that it would be that high. But a lot of the cancer treatments that are advanced are actually things that you do in an acute care setting. So I think that's affecting the approach here.
I think it's almost a bimodal distribution, David. You're seeing some, targeted surgeries getting better, whether it's breast or prostate and others. But I still think the long-term shift of care, particularly as you think about the cocktails of drugs, the targeted therapies, the immunotherapies, I think you're going to see a lot more of this being done for shorter periods in hospitals and a lot more in outpatient and managed in a home setting. Outpatient meaning it could be a satellite facility that you visit daily for your infusion or weekly, depending on the cocktail that you need to take. And certainly in the case of Memorial Sloan Kettering, they built a large group of satellites because they believe that in the future 80% of all cancer care is going to be in the community. It doesn't mean you're not connected to a hospital, but it does mean that that you're getting care in a more reasonable setting. And the more one can shift care out of the hospital, I mean, it's a material reduction in costs in terms of ongoing, even infusions. I guess the question, David, is given the health equity concerns, the increased likelihood of survival and success of cancer care, and the fact that we are changing the cost curve, how does that tie out to this consolidation, or basically hospital consolidation for cancer care? Like what matters to the patient and the policymaker?
I think that it's not correct to characterize this as a consolidation. For one thing, we've got a strong entity moving from the biggest player to the second player. So it's more like Hertz and Avis. It's actually helping them to catch up, and it's actually not a merger. Dana-Farber is staying independent and has its own board and fundraising and so on. I think we have the opportunity, John, for more accountability in this type of environment. We talk about most of people with cancer are older. And Medicare, hopefully, will be something where there's actually fewer disparities. It's not based on, do you work at a company with good insurance or not. And I think there is an opportunity as a society to actually hold these healthcare organizations accountable. And if there's only one, it's sort of like, okay, yeah, we did our best. If there's two in a city, then it actually makes it easier to measure it. And Massachusetts is a good place. I mean, keep in mind, these are all not-for-profit organizations, and they have a mission, they have some accountability, and there's an opportunity the same way you had in Massachusetts, Romney Care kind of leading the way to Obamacare. There is a real possibility to do it in Massachusetts, John. So that's my part. I'm going to put my Red Sox hat on if I can find it. I think I burned it up, though.
I based on their performance this year, I'd be much more focused on the Celtics. So, David, I think accountability is a pretty good place to wrap on.
Yeah, John, I would agree with that. And I'll hold you accountable for not running over in our session. I'll say that's it for yet another episode of CareTalk. We've been talking about Harvard and cancer. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the president of Walgreens Health. If you liked what you heard or you didn't, please subscribe on your favorite service.